Thank you, Son, for the organization, and thank you everyone for coming here this early. We're going to talk about surgical overtreatment in IPMNs. To start, we all in this audience know that pancreatic cysts are common, occurring in up to 16% of the general population using MRI studies. And this is data from a systematic review and meta-analysis that we published a couple of years ago. Now, the current landscape of management of pancreatic cysts, you can see in this figure, we usually get this detected incidentally. Patients are referred to the gastroenterologist or the surgeon, and we scratch our heads thinking, is it a mucinous cyst or not? What type of cyst type are we dealing with? Is it an IPMN, MCN, serous cystadenoma? And if it's a mucinous lesion, are we dealing with a lesion with low-grade dysplasia, high-grade dysplasia, or cancer? And to assist these diagnostic parameters, we often use MRIs and endoscopic ultrasound to try to inform these questions. But despite this, some of these questions, specifically regarding cyst type and degree of dysplasia, we cannot answer with the conventional tools that we have available. And guidelines really try to guide us about the decision-making that we have with these imaging modalities with worrisome and high-risk stigmata. And the typical decision has always been surgery, surveillance, or doing nothing. More recently, the field of ablation is growing, which is added to this part in the management of pancreatic cysts. For today's talk, I'm going to focus about the surgical management. And I will start by showing here a non-exhaustive list of different cystic lesions and the respective surgical management just based on histopathology. For the purpose of this talk, we're going to focus in the list at the right that includes cyst types that should not undergo surgery based on histopathology alone. This will include branch duct IPMNs with low-grade dysplasia, serous cystadenomas, pseudocysts, and other benign cystic lesions that we find. By far, the most common in this group is going to be the branch duct IPMNs with low-grade dysplasia that we deal in clinical practice and always try to decide, is this going to be a patient that has progressed to high-grade dysplasia and needs surgery or not? And really that what we call surgical overtreatment is going to be what we see in clinical practice of a cyst that has at least one worrisome feature, and that based on guidelines, we then recommend a surgical resection, and at the surgical histopathology, we end up finding low-grade dysplasia. So why is this important? And surgical overtreatment is an issue because surgery still is associated with mortality of 1 to 2%, morbidity such as pancreatic leak, hematoma, bleeding in 20 to 30% of patients, and there are long-term consequences, including diabetes and exocrine insufficiency. But how common is this problem? And to answer this question, we conducted a systematic review and meta-analysis that was recently published in the UEG journal a few months ago. And this included 16 studies of over 5,000 patients that had reported surgical resection and respective surgical histopathology on pancreatic cysts. So in this slide, you can see two forest plots of the prevalence of surgical resections for serous cystadenomas at the left and a benign cyst, including pseudocysts, lymphoepithelial lesion, and etc. at the right. Overall, we found that among all surgical resections, 16% were for serous cystadenomas and 4% for other benign cysts, adding up to roughly 20% of surgical resections that are done purely for benign lesions. Now, we recognize that some of these patients may have symptoms and that may have triggered an operation, but this number is still significant. Now, in this figure, you can see a meta-regression that we conducted in this same study, exploring the correlation between preoperative use of EUS and the proportion of surgical resections for serous cystadenomas. And we noticed that the rate of the resected serous cystadenomas declined as the proportion of preoperative EUSs were conducted. So this is telling us that by performing endoscopic ultrasound, perhaps we are able to reduce unnecessary surgery for serous cystadenomas. However, this does not necessarily eliminate a problem. We still have patients who have indeterminate cysts despite the conventional evaluations with EUS. Now, we're going to switch gears and talk about IPMN. And in this figure, you can see the proportions of IPMNs with low-grade dysplasia across all the different surgical series published, revealing that 24% of all surgical resections were done due to IPMNs with low-grade dysplasia. This result was heterogeneous, with some studies showing a prevalence as high as 55%. Now, when we think about all the IPMNs that we resect, 2/3 of them actually have low-grade dysplasia in this surgical series. And interestingly, you can see that some studies even reported up to 89% that in the resection there was low-grade dysplasia. And when we look if EUS is actually making a difference, we found that doing higher number of EUSs in these studies actually did not have any impact on a decreasing surgical resections for low-grade dysplasia. Now, for granted, this study did not look at the novel technologies that we have to add and to reduce these unnecessary surgical resections for low-grade dysplasia. But again, it's important to recognize that EUS alone with conventional technologies will not help us to decrease this problem. Now, we finally look at the concordance between preoperative prediction with all the tools that we have available and the final surgical histopathology in this surgical series. And only a quarter of all these cysts that we resect, there's agreement between what we think and what finally is in the surgical histopathology. And over time, I think that this misclassification has fortunately improved. However, when we look at the impact of endoscopic ultrasound, again, doing endoscopic ultrasound has not really helped us with this misclassification conundrum. But the fact that it's improving over time is probably due to the fact that MRI imaging has improved and that also, our guidelines perhaps are guiding us better with regards to this. So this sets up the stage for really having novel methods to help us differentiate about the different pancreatic cysts to decrease this problem on overtreatment. And we have different tools that we have available in clinical practice now. We have confocal endomicroscopy, molecular analysis, and cyst biopsies, some of which we're going to discuss today. But in addition to that, there's significant growth in other areas, such as applying AI, radiomics, and perhaps blood markers that can help us really differentiate these patients and avoid surgical overtreatment. So we conclude to say that based on this study, near half of the pancreatic surgical resections for cysts are possibly unnecessary. And this is mostly driven by surgeries of serous adenomas and IPMNs with low-grade dysplasia. So these are the real big two type of cystic lesions that we want to try to focus to mitigate this problem. Now, for serous adenomas, I think that we have good technologies. If it's a microcystic lesion, even a fine needle biopsy can be available to diagnose this with histopathology. And when we don't really, have that, we have molecular analysis and confocal endomicroscopy that have very good accuracy. And it's just a matter of us implementing some of these tools for some of these cysts. But for IPMN, it's really where we need to adopt and generate novel methods to decide when is the time to operate in these patients and hopefully decrease this phenomenon of operating in so many patients who have low-grade dysplasia. Now, for granted, sometimes we want to decrease the progression to that risk of high-grade dysplasia, but we currently do not have tools either to know who are going to be the patients with low-grade dysplasia who may progress soon into high-grade dysplasia. So with that, I want to thank everyone for your attendance, and I'm going to pass it to Dr. Chari, who is going to talk to us today about navigating evidence-based frameworks and emerging innovations. Thank you, everyone.
Thank you, Sol and team, for the invitation to speak today, and Jorge, you have set the stage very well for moving this forward. How do we move? Oh. So my role today is to discuss, as a non-therapeutic endoscopist, the issues we face when seeing a patient. And there are three tensions I've identified. The tension between biology, what the tumor is doing, versus what the morphology is telling us, which is where much of the stuff that Jorge talked about is happening. The second is what's the tension between innovation that we're going to talk about today versus the evidence. And lastly, the patient in the middle who is worried of cancer on one side and wants to know what the status of a cyst is on the other side. And this creates tension. And many of the cases that go to surgery may be because the patient is pushing for it. So it's a complex topic and needs more thought. So as we all saw, there is a cyst pandemic with 8% prevalence, 80% being branched like IPMN, less than 5% actually going on to cancer, and significant minority of this thing having cysts that are benign or low-grade dysplasia. We just saw that that's the case. So we have built a surveillance system for all comers, largely low-risk populations, and it now consumes enormous resource while missing the few who progress. So this is a challenge we face, is that we have an enormous burden, and the needle in the haystack can often be missed, or in the process of trying to avoid that, you end up doing something which is not necessary for the patient. So the first tension is technology pushing ahead of validation. So this is constant in the world of innovation. We always come up with an idea that's not yet fully mature, and its adoption is waiting for evidence. So we're going to discuss many innovations today and what they will offer and what the validation gap is for each of them. And you will hear it from the speakers who are authorities in the field. But each of them offers you something that is better than what we have today. And each of them has a validation gap that requires to be filled in order to come into practice. And also, some of these have steep learning curves that require very specialized training in order to be able to do these. So they come with their own caveats. They're not available in every center. The patient is sitting in an office where these things are not available. What do the physician do? The technology is ahead of the evidence, and our patients are watching us decide how we use this. So again, something that is one of the prime tensions in this area. I have actually seen patients who have been to a physician for a problem that has a very easy solution not available in that institution. Most people will default to what is available in their institution and say that is as good as what you're going to get when you go 1,000 miles away. So this is another thing. You use the hammers you have, and how do you make this, percolate this to make sure that it's available everywhere, and the best use of these technologies is made. The second tension is the guidelines versus conservative. They are conservative by design, protect against unnecessary surgery in low risk cysts, but also protect against progression to cancer. So they themselves have a tension there. Provide consistent auditable decision thresholds, high sensitivity for high risk stigmata, discontinuation rules limit surveillance burden, and proven safe, low rates of missed cancers in surveilled cohorts. That's the thing. There's a tension between what proportion of your cases can have low-grade dysplasia versus what proportion of patients can escape your surveillance and develop advanced disease where you have not helped the patient after watching them for 10 years. So there's that tension. What the guidelines cannot do is detect biological risk before morphological change. That will require some invasive procedures. Distinguish the 5% who progress from the 95% who don't. Account for cyst fluid molecular signatures, because without the cyst fluid, you can't do that. And again, there are some host metabolic signatures that are being now considered, and obviously the guidelines are not there yet. And the problem of over treatment. Guidelines are morphology first by necessity, because the patient is coming to you because they found something on CT. The field now has tools to add biology, but not the trials to mandate it. So again, it's a burden of proof question. The third tension is the patient, anxiety and the desire to know. And the Pacific trial has done a very nice job of looking at the psychological burden on the patient when they go through these surveillance protocols. Our decisions are often driven by what the patient cannot tolerate, not what the data support. And this is one of the important things I think to remember. In a 60-year-old who has got a 2.5 centimeter cyst, he said, "I don't want to deal with this. Just take it out." And that goes against the surgeon or the this one that is a low-grade dysplasia, but it's the patient's intolerance of uncertainty. So in this studies, 82% say surveillance reduces cancer concern and gives them a sense of certainty. Somatization, depression, anxiety, and sleep disorders significantly higher in surveillance versus surgical groups. I remember my patients every time telling me that they don't worry about the surveillance until a month before their next appointment, and they start worrying what this MRI is going to show. 30% that had sleep worse after starting surveillance than before. And 8 to 95% cancer worry ranges considerably, and this depends on the patient's mindset. The clinical tension is this: the patient saying, "I don't want to watch something that might turn into cancer." And that puts you in a difficult situation. Surveillance creates a sword of Damocles effect because it's going to feel like I'm next. And so it's very difficult to get it out of the psyche. Intolerance of uncertainty drives demand for intervention. And new tools feel like answers, but may treat anxiety, not biology. So that's the attention that those who are promoting these should know. Are we treating biology or helping us both tolerate uncertainty? So this session covers much of what I've told you, that the innovation, and they're going to present to you what is good about it, where are the gaps, and where we need to go forward. And we need to understand how to put all this together in the practice and keeping the patient in the center of all of this. So a framework for the clinician at the bedside: when to navigating the three tensions in real practice, when to follow guidelines: low risk Blanchard IVM without worrisome features, patient not fit for surgery, stable cyst, unchanged for 5+ years, cyst less than 1.5 centimeters. And you can keep arguing. I mean, whenever I tell this, a surgeon will show me a cyst that was 5 millimeters and had cancer. Now, that's an exception to the rule and should not drive our decision making, but largely we should stay away from surgery in these patients. When to consider new tools: indeterminate cyst after FNA CEA, mural nodule requiring characterization. Patient and clinician both need more certainty. Available at high volume expert centers. When to directly address anxiety with the patient. Patient driving escalation of care despite low risk features. Gotta have time to sit down, hold the patient's hand, and guide them through this anxiety period, because time is a great healer. You get 6 months later, they find nothing has happened. They'll heave a sigh of relief, and everybody will feel better. But it takes time to do this. Explain absolute, not relative risk clearly. Co-produce the surveillance plan with the patient. If you unilaterally impose it on them, they may not appreciate it. Name watchful waiting as an active, valid choice, as opposed to saying, well, let's see what happens next time. That creates tremendous anxiety. Key principle: use new technology to change biology, not to manage anxiety. Then acknowledge and address anxiety separately. So I'll try and resolve these three tensions. It's not obviously easy. It's not going to go away. But biology versus morphology. The morphological thresholds are a necessary proxy, not the final answer. Molecular and metabolic signals can stratify risk earlier, but must be validated before putting into practice. Innovation versus evidence. We see all these advances. Amazing. They have to be made because we have gaps, but not yet ready for universal adoption. Treat innovation as a precedent tool, not a default response to uncertainty. And finally, cancer risk versus patient anxiety. Anxiety is real, valid, and clinically important. The answer is clear communication and shared decision-making, not reflexive escalation of diagnostics and treatment. Our challenge is not only to align emerging diagnostics with evidence, but to align them with our patients' values, treating biology, not just anxiety, while honoring the very human need to know from the patient standpoint. Thank you. Appreciate it.
So for those that don't know me, my name's Atur Singhi at the Department of Pathology here at at UPMC. Remember, I'm a pathologist. It is early, so I might be off my A game here. So my apologies. And when I had to put this together, I was like, well, if they're going to make me talk this early in the morning, and as some of the people that UPMC know, I don't like getting up early, especially for tumor boards, that I'm going to have a little fun with that. And so first and foremost, I have no relevant financial disclosures or relationships. I know this seems hard to believe, especially with Pancreatic and Biliseek. They were created based on donation dollars from patients. They were created based on NIH funding. We've always said there's no IP, there's no patent, there's nothing on it. It's completely open. We just don't want people doing it the wrong way. When it comes to updates, I was told to updates on 2026 some, and so I'm going to be a little fun with this. And I'm going to say that first, my update is to Dr. Chari. Over the last decade, I can't tell you how many times Suresh raises his hand right at the end and says, Atur, is this covered by FDA? Is this covered by the Medicare? And so I'm going to tell you today, Medicare reviewed Pancreatic positively and agrees that molecular testing of pancreatic cyst fluid should receive broad coverage as of last week. And in their opinion, no additional data is now required, and that they have asked us to write the Medicare's intended LCD. There is no LCD for pancreatic cysts. There's pancreatic cancer or cancers in general. There's pancreatitis. There's nothing on pancreatic cysts, which is a huge deficiency that they recognize, especially with the unfortunate problem of having more and more patients that have Medicare that have pancreatic cysts. And the reason is that really the limitations is that DNA alterations alone cannot distinguish between IPMNs and MCNs. We still have cysts that cannot be distinguished between a molecular alteration that's present, that being KRAS mutations. In addition, VHL alterations are associated with xerostomos that are very challenging to identify with current sequencing strategies. And it's still difficult to molecularly detect high-grade dysplasia and invasive cancer associated from a pancreatic cyst fluid. Therefore, our newest panel, Pancreatic Genomic Classifier, or Pancreatic GC, represents our first foray in not only DNA-based testing, but RNA sequencing to address some of these limitations. For example, IOPNs, as Jorge had mentioned, is a high-grade dysplasia. It often is associated with high-grade dysplasia and 30% of pancreatic cancer, and that's why it's a green light to go to surgery. But these are characterized by fusion genes, which you cannot detect by DNA alterations. That's literally 1% of all pancreatic cysts are an IOPN. They have high-grade dysplasia. 30% have pancreatic cancer. They are 50% of which are missed by cytopathologists, because I know that when I sign them out, that they're really challenging. Cystic pancreatic neuroendocrine tumors can be identified using chromogranin RNA testing. They can be devoid of genomic alterations, but be characterized by chromogranin elevation. And then in a side-by-side comparison that we just published versus DNA RNA testing, we found that there was a 7 to 10% improvement in the detection of mucinous cysts and advanced neoplasia. But Pancreatic represents, or Pancreatic GC, I should say, represents a cherry picking of RNA genes. Based on the literature, it's not comprehensive. Ideally, we need to cover the entire RNA landscape to really identify which RNA-based biomarkers are important and which ones are not. And that's where we need to figure out ways to stabilize the RNA first and then explore after. And that is really the crux of the matter is when we developed Pancreatic, we didn't think about shipping, where you're going from, let's say, the Gulf states, or excuse me, that being said, literally China going to University of Pittsburgh Medical Center. There's a lot that goes in between. And so we need to be able to preserve an RNA-based specimen, that being said, even a DNA-based specimen. And so that was where PancPreserve has actually gone through multiple generations. It is an RNA collection as well as DNA collection buffer that really can cover multiple assays, those that do bile duct testing, those that do pancreatic cyst testing, those that want to even do solid tumor testing, or even take cytology slides and isolate nucleic acids from those cytology slides because they don't have a cell block. You can use this. And so armed with that, we started delving deep into the whole transcriptome of pancreatic cysts in the last year. We optimized it on just 100 microliters of pancreatic cyst fluid to identify potential RNA biomarkers. As I mentioned, there is no literature to help me identify the best RNA biomarkers. So honestly, this is the first time we've ever dealt with when it comes to discovery. And that's where we took 966 specimens across 11 diagnostic categories. Then planning was to combine RNA with DNA to create a classifier We've always dealt with classifiers when it comes to pancreatic cysts, that being genomic classifier or GC, to potentially improve the evaluation of cystic neoplasms, and then lastly resulting in a DNA RNA panel that we would validate, and we've always validated biomarkers. So once again, upon whole transcriptome sequencing of 966, we've gated so that we can identify an RNA marker that is so specific for that diagnosis, again, off 966 cases, to identify those markers that are the most challenging for us to determine based on our current platforms. And that is, honestly, mucinous cystic neoplasms. It is really hard to identify mucinous cystic neoplasm based on cyst fluid. But with markers like FOXL2, which we've now actually validated on corresponding tissue from surgically resected patients, we can actually identify a biomarker from the cyst fluid that's not even on the epithelium. It's actually in the stroma, which then opens the door that I can actually look at immune cells now with RNA. Very often, your cytopathologists are citing out, oh, there's lymphocytes, neutrophils in the cyst fluid. What does it mean? Well, actually, we can quantify that at the RNA level, where we didn't used to have that ability because we have no cell blocks. We have nothing to test with an ancillary study. But at this point in time, we are actually able to look at the immune environment overall. And then combine that with our corresponding DNA alterations, because DNA is still worthwhile in general. I'm not saying it's useless, but I think it is extremely important to add on biomarkers. Now, obviously, this is all at a cost. You'd be surprised, but RNA is actually half the cost of pancreatic GC. But then, therefore, we need to validate the findings. And so over 328 cystic pancreatic neoplasms in comparison to DNA-based testing alone, DNA and RNA sequencing has improved the sensitivity of MCNs. We've jumped from 40% to 73.3%. I'll be honest with you, this is just the beginning. We are extensively evaluating a lot of cystic neoplasms that come through the door at UPMC, and then trying to improve on our current biomarker strategy, but really increasing the specificity from 77% to 99%. In addition, the assessment of PRKACA and PRKACB fusions, actually there's a lot more that we didn't publish that is going to be coming out very soon, but they are 100% only associated with IOPNs. You really have a strong signal for IOPNs when you use RNA-based sequencing. That also includes neuroendocrine tumors, which we know is increasing. We're starting to see a lot more neuroendocrine tumors. We need to prognosticate them, and this is where I think RNA-based testing will help the most. But more importantly, we saw an approximate 10% increase in sensitivity for high-grade dysplasia and cancer within our validation cohort. So to summarize, because I only have 9 minutes now, I only have 1 minute left. So the application of DNA-based testing of pancreatic cyst is honestly here to stay. It's not going anywhere. It will be adopted. It's going to be integrated with Medicare. It's here. Why not use it? Now, I would say that in addition, combining RNA with DNA testing shows improvement in diagnostic accuracy of classifying pancreatic cysts in both high-grade dysplasia and early invasive adenocarcinoma. But considering the retrospective design of this study itself, and you'll hear a little more about it today at DDW, what we're right now focused on is prospective validation. That has always been the key for us, that we need to see what it does actual in clinical practice. We've been always a little experimental with our patients, I get that, but I think that's extremely important. In addition, because of the large amount of data, I can't handle all of that, and UPMC can't handle all that. So thankfully, Microsoft has actually decided to lend us a hand, and their nonprofit Microsoft's AI Laboratory for Good has been extremely helpful in actually integrating that to hopefully create a scalable targeted DNA sequencing panel that doesn't just take into account the molecular, but it takes into account the imaging, family history, patient's age, the cyst location, and that's honestly not going to be us that can actually do that, that being a pathologist. That's really going to be an AI tool overall. And with that, I'll turn it over to the next speaker. Thank you. Good morning.
So we have been through this slide before, that it's challenging to diagnose pancreatic cysts using current modalities. And the whole idea is to get exposed to various diagnostic modalities and their disadvantages and advantages as well. So these are the advanced modalities we have: endomicroscopy, molecular analysis, and tissue acquisition methods, which includes TTNB, through the needle biopsy, and fine needle biopsy. So what is endomicroscopy for those who are not too familiar with it? It's currently applicable through a 19-gauge needle. We have to preload a laser endomicroscopy mini probe through the needle, and the other end of the probe gets connected to an endomicroscopy processor. And once you're in the cyst, you advance the needle to the cyst epithelium, and then you advance the tip of the probe beyond the needle tip, and you can get representative characteristic images of each cyst type as you kind of get the video from the inside the cyst. Now, in this CLIMB multicenter study, which we started back in 2018, we sought to evaluate the performance of endomicroscopy, specifically in larger pancreatic cysts. We evaluated the diagnostic accuracy of endomicroscopy in a prospective multicenter study. This was initiated in 2018, and the study spans 16 US centers, includes 24 advanced endoscopists, and has enrolled more than 600 patients, cysts larger than 2 centimeters. The study design, as you see in the flow chart, is fairly straightforward, where we perform endomicroscopy first, and then once the probe is taken out, the needle is still in the cyst, we aspirate the fluid, and then so also in cases, we get tissue histopathology as well. Now, here is the flow chart which the CLIMB protocol follows, and I'm just going to go through this flow chart in the next couple of slides and just kind of painting clinical scenarios. In case you have a multiseptated cyst, not classic multicystic, but septated cyst, it starts with endomicroscopy because we go with the needle is preloaded with the endomicroscopy probe, and then we get a diagnosis right away. So here we see papillae in IPMN. In some other cases, we may see flat epithelial bands, which is mucinous cystic neoplasm. So in both these mucinous cases, once the imaging is done, the needle is still in the cyst, probe is taken out, we aspirate the fluid, send it for standard markers, including NGS. Now, in case you see what looks like neuroendocrine tumor, and that's the pattern at the bottom there, which is nests and trabeculae of cells. And again, we aspirate, and then we send it to immunohistochemistry because that's important, because we do have a clue into the diagnosis as what it is from endomicroscopy. So for these type of lesions, the evaluation stops right there. Now, in case you encounter a microcystic lesion, which is classic for serous adenoma, you know the challenge that it's difficult to get free fluid, and we do start with endomicroscopy, and here you see this Fern pattern of vascularity, otherwise called superficial vascular network. And as I said, it's challenging to get fluid. So what we do is we take the probe out, the needle is still there, and we use a modified wet biopsy technique to get a core tissue, and that goes to the pathologist, and they give us an answer as to what the final diagnosis is. It's part of the study protocol. It's not that you have to get a specimen when endomicroscopy has diagnosed the case, because for the study, we do need references to pathology. Now, in case it's a macrolocular cyst or unilocular cyst, and you do get the same pattern of serous adenoma, even then we get the imaging, get the fluid for NGS and all the routine markers. And finally, if we're encountering a rare type of cyst, as here you see a lymphoepithelial cyst, here endomicroscopy has heterogeneous image patterns. So we do get the imaging, we document the imaging, and then we document it's a non-missense cyst, but we really cannot say what kind of cyst it is sometimes for the rare types. We collect the fluid, and then here in these cases too, when we don't have a diagnosis, we get a biopsy of the wall using through the needle biopsy forceps. So here are the results. So there were 263 patients with definitive histopathology and a near equal distribution of mucinous and non-mucinous cysts. The mean size of the cyst managed on the study was 4 centimeters. The mean duration of endomicroscopy per case was 7 minutes. Now let's talk about the adverse event rate. The overall adverse event rate was 4.5%, driven mainly by pancreatitis, which is 4.3%. But then 18% of the entire cohort had through the needle biopsy. But when you separate those two cohorts, just endomicroscopy alone, pancreatitis rate was 4.1%. And in the combination, those who had endomicroscopy and through the needle biopsy, the complication rate was 5.4%, but there was no statistical difference. Now, when you look at this recent study where they did a meta-analysis of nearly 900 patients who underwent FNA with 19 gauge needle, that's just plain FNA with a 19 gauge needle in pancreatic cyst, the reported pancreatitis rate was 3.6%. And the rate of pancreatitis because of NCLE alone falls within that 95% confidence interval. Now let's talk about the results. And while endomicroscopy showed an overall accuracy of 93% with equal sensitivity and specificity, it was better than standard of care markers, which is CEA, cytology, and glucose, where the accuracy to differentiate mucinous and non-mucinous cysts was 83%. But the last row where you see the results of NGS, this study started back in 2018, and there were labs which were using older methods, called Sanger technique. And so also there was kind of heterogeneous practices. And that's, in fact, makes a strong reason why we should, Arthur's talk was really kind of showing us this high accuracy. I think it's a strong reason really for us to streamline the flow of NGS into one center or one lab, which can potentially give us the highest accuracy results. And of course, what Dr. Singhi pointed out, we have had issues with our institution sending out the samples and forcing us to do our own analysis because of cost issues. But I think that's a continued discussion we're going to have at OSU. Now, when you look at each cyst type, endomicroscopy achieved greater than 90% accuracy for diagnosing each of the common cyst types. Importantly, endomicroscopy demonstrated the highest accuracy for diagnosing serous cystadenomas. Now, two things. To differentiate MCN and IPN, especially when the IPMN is low grade, it tends to be challenging if the lesion is in the body and tail, because you will see flat, low-grade epithelium, so you may not be able to really differentiate if it's MCN and IPMN. It's just like getting KRAS in a unilocular cyst, isolated cyst, and you really don't know if it's MCN or IPMN. And the other is endomicroscopy cannot differentiate between neuroendocrine tumor, cystic neuroendocrine tumor, and solid pseudopapillary neoplasm, because they have the same endomicroscopy imaging with clusters and groups of cells. So how does this compare to prior studies? So we had a prior contact study and index study with a smaller patient population. And here we have nearly 5 to 7 times the patient population, and we have 16 US centers with multiple endosonographers. Overall, there was no statistical difference, and the accuracy dipped a little bit, which was expected. And but still, I think it continues to be high. So what's coming in the pipeline? The biggest issue, which I talked to multiple endosonographers, advanced endoscopists, one of the biggest roadblocks has always been the use of 19 gauge needle. If you really cut across 19 and 22 gauge needle, the 19 gauge needle is 120 times higher in surface area compared to 22. And pancreas is a small organ, the cyst is smaller, and the cyst really feels it. One of the reasons I think the pancreatitis rate is high is because of this 19 gauge needle. So I think with the permission from Mauna Kea, we were able to have this photograph here. There is a new probe coming out, which is a 22 gauge compatible NCLE probe. And they were somehow able to fit in 10,000, the same amount of optic fibers into that 22 gauge compatible probe. So we're going to, right after the talk last night, which it was a similar talk on client study, and I had multiple people come and talk to me and said, they're really excited about this probe, and they will hopefully use it, given the fact that we have so many studies, validation studies, showing how good the imaging is. So in conclusion, endomicroscopy provides accurate differentiation and diagnosis of pancreatic cystic lesions. We do look forward to the 22 gauge compatible endomicroscopy probe expected next year, which will likely lower the barrier to routine clinical use for pancreatic cysts. Among all the diagnostic tools available, endomicroscopy serves as an anchor piece of cyst diagnostic puzzle in the CLIMB multicenter experience. Thank you.
Good morning, everyone. Thank you, Sam and the OSU team for organizing this conference, and thank you for the invitation. The goal of evaluation of pancreas cyst is to get as much information about the cyst, and the ultimate goal is to prevent, the cysts that don't require surgery to go for surgery and have the comorbidities and the potential mortality from that. And endomicroscopy is one of the tools that we have at our disposal that we can use to get as much information as possible. But in order to attain this goal, we need to optimize imaging using endomicroscopy. So the goal of this talk is to talk a little bit about the mechanism of confocal endomicroscopy and also tips on how to optimize imaging during the procedure. So this is the probe, the mini probe that's used during endomicroscopy. It has about 10,000 optical fibers. And in fact, to concentrate this into a probe that can go through a 22-gauge needle is really a great achievement. So currently, this probe goes through the 19-gauge needle that we feed the probe through, and it emits laser light that goes through this lens that concentrate the light into the surface of the cyst wall. And with fluorescein injected prior to the procedure, the fluorescein gets excited and reflect the lights back into the lens and then get concentrated through a pinhole to get the high resolution imaging while dispersing the lights that will get the image out of focus. And with this imaging, the high resolution imaging is about 3.4 micrometer in resolution and lateral resolution at about 1,000 magnification. So during the procedure, it's really important for the endoscopist to have both monitors of the EUS and the NCLE in his field of vision. The reason for that is you need to correlate the location of your needle and probe with what you're seeing on NCLE. And with the EUS, you move the probe along the wall, and at the same time, this is guided by your EUS so you can see the NCLE images. During the procedure, after you advance the needle, it's important to get en face imaging from the cyst wall, as well as tangential imaging. En face imaging are extremely important to get optimal imaging of IPMNs, serous cystadenomas, and cystic net tumors, while oblique imaging or tangential imaging are important in order to be able to identify the epithelial bands in patients with MCN. So I'm not going to go through the assembly of the procedure of the mini probe and the 19-gauge needle, but the tools that you need are 19-gauge needle and the mini probe, the Acuflex mini probe, as well as the connector, the disposal connector that you need to use in order to connect the mini probe to the needle and then advance it into the cyst. So after assembly, you have to pull the mini probe out of the needle so you can puncture the cyst with the needle. And then once inside the needle, you readjust the connector so you can have the tip of the mini probe about 2 millimeters from the tip of the needle. And here with EUS, you can see the needle as well as the tip of the mini probe. You have to keep this in view all through the procedure so you know exactly where is your mini probe in respect to the wall of the cyst itself. So during the procedure, it's really important to move the needle along the wall of the cyst in order to examine as much of the cyst surface as possible. And to do so, you have to really use a lot of elevator movement, as well as body movement, and a little bit of big wheel and small wheel movements. And the goal is to try to examine as much of the cyst wall as possible. With a 19-gauge needle, it's not really an easy thing to do. And hopefully with a 22-gauge needle, we'll have more area of the cyst that we can examine. But it's important really when you are really moving the needle to pull the needle back and try not to really damage the wall of the cyst when you're doing this maneuver. So you pull the needle back and you try to change your position, and then you adjust the mini probe so you can do examination of different areas of the cyst. Sometimes when you advance and you're inside the cyst, you might have an artifact at the tip of the mini probe, And all what you need to do is to try to advance the mini probe to the wall of the cyst and then withdraw it back. And that can get rid most of the time of the artifact that you get on the probe. The first minute, you always have problem with the imaging. Don't panic. Just wait a minute. It will take about a minute for the process to calibrate itself, and then we have a clear image after that. With site-separated adenomas, they're very vascular, and you might hit the vessel during the procedure, and you might get bleeding, and you see, like in this case, you see the bleeding, and that can, mask the pattern of the serous cyst adenoma. In that case, all what you need to do is to move your needle to another place and try to find another area without trying not to damage, the wall of the cyst while doing that. So challenges with NCLE, serous cyst adenomas, you have to make sure that you're not damaging the wall in order to cause no bleeding. There is variation in the fur pattern. So you will not see the typical fur pattern in all serous cyst adenomas, but the key in these cases is not to see epithelial pattern. We don't see epithelial pattern with dense, intersected blood vessels, then this is a serous adenoma. With MCNs, the challenge is to try to get the band epithelium. And tangential view of the cyst is essential in order to get these band epithelium. With MCN also, you might see chronic inflammatory cells, which is something you see with pseudocyst. But in pseudocyst, you don't see these band-like imaging. So this is kind of the distinguishing between the two. Cyst, net tumor, and solid pseudopapillary tumor of the pancreas, they look the same on NCLE, and they require biopsy staining in order to distinguish them from each other. So with MCNs, this is very challenging. The pathognomonic histologic finding is ovarian stroma. You won't see that with NCLE as they are subepithelial, but you need to rely on the epithelial band, which are tough to see. But you have to really examine as much of the cyst surface as possible in order to be able to find them, especially with MCNs that have a lot of denuded epithelium. So it's really challenging to do that, and you need to really increase the surface of your examination to try to pick up these epithelial bands. Here in this video, the first one, you can see the epithelial bands, these parallel lines of cells. In the second video, at the end of the video, you'll see the epithelial bands also with intersected blood vessels. Here you can see the bands. You don't see like a full papilla, but you can see the bands suggesting that this is an MCN with low rate dysplasia. With IPMNs that have advanced neoplasia, you might have very complex vasculature that looks like a serous cyst adenoma. A lot of intersected vessels, dense vessels, but in the presence of epithelial cells and projected papillae, this is not a serous cyst adenoma. As you see in this case, this will show a very thick papilla, very dark, thick, related to the fact that the nucleus is large and you have pseudostratification in case of high-grade dysplasia. And at the end of this video, you see a very complex vessel, suggesting that this could be like, a serous adenoma, but in the presence of epithelial cells, this is not a serous adenoma, this is an IPMN. We know with NET and pseudopapillary tumor of the pancreas, they have this trabecular, features. These are, clusters of dark cells that are separated by fibrovascular stroma. They both look the same. You can't distinguish them based on NCLE, so you're going to need to do biopsies, and biopsy yield is really high in these cysts, and you need image staining to be able to distinguish both. So NCLE is one of the tools that we use. We have to use it hand in hand with other modalities in order to get as much information about the cyst. And the goal again is to make sure that the cyst, the benign cyst, serous adenoma, or low-grade display, low-grade IPMN won't go to surgery for these indications. Thank you.
Hello, everyone. My name is Ahmed Abdelbaki. I'm a postdoc fellow at the Ohio State and an incoming B2Y1. This work is part of an R1 NIH-funded program focused on a central question. Can we build a fully autonomous AI system that is capable of classifying IPMN dysplasia through endomicroscopy? Today, I will walk you through our journey. To answer the question of why AI and how it can help, we need to understand the challenges that we might face with the interpretation of IPMN dysplasia classification through endomicroscopy. These videos are of endomicroscopy from different IPMNs. As we can see, these images shift rapidly, compounded by the patient breathing and the diaphragmatic movement, with approximately 20% being informative out of the whole video. Collectively, human classification of dysplasia can get challenging, often leading to inter-observer disagreement. To address and overcome these challenges, we developed NCD-AI, a deep learning model trained on EUS endomicroscopy for the detection of advanced neoplasia in IPMNs. Our aim was to streamline the process of AI risk assessment of IPMNs by combining endomicroscopy and other possible clinical variables. Starting with raw NCD videos, we can get a frame-level classification, which can then be integrated with other clinical variables of guidelines like Fukuoka or the most recent, Kyoto, to optimize the case-level dysplasia classification. 3 publications mark our journey that started in 2019, from manually curated endomicroscopy NCD videos published in 2021 to our latest publication in 2025, a fully autonomous AI model that can do risk assessment on its own. Our journey starts with this publication in 2021, with an initial proof of concept. Working with 35 patients and over 15,000 NCD frames, we trained 2 CNN models, a holistic and a segmentation one. These looked into the thickness, darkness, and the size of papillae on NCD to assess the degree of dysplasia. Both models outperformed Fukuoka and AGA guidelines in sensitivity and accuracy. This diagram represents the pipeline of our first algorithm. For step 1, we have human-edited NCD videos with high-yield segments to feed into the AI model for dysplasia prediction. But the limitation, as mentioned, these models require expert pre-edited videos for step 1 of the pipeline, and these can be cumbersome. The next version of the algorithm aiming to resolve this limitation was published in 2025. Working with 66 patients and nearly 300,000 label frames, we trained and tested multiple algorithms on full-length unedited videos. The winner of these was DynoV2, a classification model that achieved an AUC of 0.42 for detecting papillary structures. The practical impact of this is reduction in review time needed for each case, where AI could create a high-yield edited videos for each case with no human intervention needed. This figure shows the AI training process using expert annotated frames. We trained the classification and segmentation models. So as we can see, the system does more than just detect papillae. It's also able to classify vascular, avascular, and non-informative frames, allowing it to highlight relevant findings while filtering out non-informative segments. In addition, we explore segmentation models, and as the name implies, these can have segmentation masks on each structure within a frame. On the left, we can see examples of low-grade dysplasia, and on the right, high-grade dysplasia. These videos are slowed down so we can appreciate the structures. For each, the first column shows the original NCD video, the second column displays NCD AI detection of papillary structures, and the third column presents a carefully labeled frame-by-frame human annotations that we use to establish the ground truth. Human labeling takes a tremendous amount of time and effort, and as we can see, NCD AI shows a near-perfect alignment with human labeling in columns 2 and 3. And finally, our most recent publication where we compared a fully autonomous AI model to human observers. The NCD AI algorithm follows several steps. We start with an unedited endomicroscopy video that is about 5 to 10 minutes in duration. Next, AI detects the frames with papillae while rejecting frames without meaningful structures. The next step is a frame level classification where each NC frame is then classified as mild, moderate, or advanced degree of dysplasia. And for the last step, a logistic regression model combines the frame level data to give a case level dysplasia classification. This approach with a logistic regression model allows for flexibility, enabling the combination with additional variables into the logistic regression model, such as Kyoto guidelines, Sysflood NGS, and MRI radiomics. Putting NCD AI to the test, we compared its performance to experts. We provided full-length endomicroscopy videos and Fukuoka variables to 16 human experts and NCD AI at the same time, utilizing a prospective dataset of 60 resected branch duct IVMNs with pre-surgical NCD. And then we compare the performance of human observers and NCD AI for detecting advanced neoplasia. As we can see, NCD AI performed better than humans who had a fair kappa value of 0.29, achieving a higher and a more balanced sensitivity, specificity, and overall accuracy. Subsequently, we incorporated the updated Kyoto criteria into the NCD AI model. While Kyoto high-risk stigmata alone had a low sensitivity but a high specificity, when we added the Kyoto criteria to the AI model, it achieved a more balanced sensitivity, specificity, resulting in an improved overall accuracy of 83%. Future plans. Prospective testing in a multi-center setting is required to validate our results with the ultimate goal in mind of developing a fully autonomous AI model that is able to do real-time intra-procedural risk stratification. In conclusion, inter-observer variability and challenges in image interpretation can potentially limit IPMN NCD-guided dysplasia classification by humans. NCD AI can improve risk stratification of IPMNs, performing better than human observers. NCD works synergistically with Kyoto criteria, further improving IPMN dysplasia classification. Thank you. I'll now pass it to Dr. Moses.
Great talk. I just want to thank Sam for asking me to talk here today, and I just appreciate everybody here showing up early and coming to listen to these fantastic talks. And I'm going to talk to you about a very exciting, minimally invasive treatment option for pancreatic cysts that in appropriately selected patients is exciting, it's developing, it's here, and I want to tell you about it in 10 minutes, which is impossible, but we're going to see what we can do. I'm not talking down to you. I know that this group knows this stuff, but I do want to frame the magnitude of the problem. Pancreatic cancer is huge. It's getting worse. And what I'm going to propose to you today is that we can take the colonoscopy polypectomy model. This isn't a perfect mirror analogy, but it's close. Remove the precursor lesion and prevent the disease, a model which has been incredibly successful in colonoscopy. And I'm going to try to convince you today that for a subset of patients, we can do that here. So this is the bad actor we're talking about, the precancerous mucinous cyst. Very common. In fact, I used to say 2% based on the European series, but Mike Wallace's group just published some data that could be as high as 42% prevalence with new MRI technology. So very common, kind of similar to a colon pop, you might say. And overall, their oncologic risk is otherwise characterized by 10 high-risk features or worrisome features called in the Kyoto guidelines. And that's what dictates their behavior over the next 10 years. So I don't know that everybody appreciates that there's two pathways to pancreatic cancer. There's the pan-in lesion, which is your microscopic degeneration of ductal adenocarcinoma, which tends to happen at the periphery of the ductules, tends to happen in the head of the pancreas, and their macrocystic event of the mucinous cyst, which is a macrocystic development, degeneration of oncogenes, a loss of tumor suppressor genes, progressive over time. I don't want to overdo the analogy, but akin to the colon adenoma. That gives us the ability and the opportunity to interrupt that sequence. So In this group, you'll be familiar, there's always been two options, endless surveillance and surgery. I'm going to try to convince you that if for appropriately selected patients, we can take the morbid, costly, disfiguring option of surgery and replace it with a minimally invasive option that is effective, much more cost effective, much more popular with patients. They can be home in time for lunch, and much less expensive. This is not for cancer. This is for appropriately selected mucinous cysts. Okay, so how's this work? Well, it's a little bit tougher than this, but the needle goes into the mucinous cyst. You draw all the fluid out, leave a little rim of mucin around it to make sure that you don't scratch up the walls during respiratory excursion, coughing, or retching, and you replace the exact same amount of a custom chemotherapy admixture that's specifically designed for pancreatic neoplasia, mixture of paclitaxel and gemcitabine. This is the first randomized clinical trial we performed. This was to prove the idea, the hypothesis that alcohol is not required for effective pancreatic cyst ablation. Anybody who remembers the original trials, they were based on alcohol. Some were effective when they replaced alcohol and added chemotherapy, much more effective, but all had a significant profile of adverse events blamed on the inflammatory results of alcohol. These trials, if you see the top horizontal line, that's the alcohol-based ablation. The second horizontal line down is alcohol-free chemoablation. You can see a complete response rate, 61 for alcohol, 67 for alcohol-free, no change. Alcohol is not required for effective pancreatic cyst ablation. The more significant element is in the serious and minor adverse events. They're all localized in the alcohol arm. When we remove alcohol from the ablation process, adverse events fall significantly, adding to its attraction as a treatment option. How do we know it worked? Well, we measure the cyst beforehand. We put it into a calculation, 4/3 pi r cubed, which, if you remember from high school, is your volume calculation. R is your cyst radius. And then you want to measure it at 1 year. If it's 95% or less, that's complete. 75% or greater, that is partial. 95% or greater, I meant. And this one's obviously greater than 95% because you can't find it. That's complete ablation. Always measured at 1 year, always by MRI, MRCP. All right, does it work? Well, there's two important things on this graph. This is our overall patient performance, and you'll see that that they have a vibrant response by 6 months. Most have a complete response or partial response. There are such things as non-responders. So if you think this is magic and it's 100% effective, it's not. Just like Barrett's ablation, there are such things as non-responders. But you'll see on this graph that it takes a full year to show effect. This is the difference between alcohol-free ablation, atraumatic ablation, and traumatic ablation, heat, alcohol, something like that. Traumatic ablation happens all at once, and you see what happens months later. Alcohol-free or atraumatic ablation happens over weeks to months. It's a constant, slow process. This is important. I was just talking to Nick Shaheen yesterday, and we made this correlation between his long-term data on Barrett's esophagus because he was getting a lot of criticism that how do you know RFA will work? How do you know there's not cancer that you burned in there somewhere? He answered that with the long-term data, and that's what you're seeing here. How do you know it's gone? How do you know it won't come back? How do you know radiographic response means clinical response? This is how you do it, long-term follow-up, and we saw that 87% of our patients who got complete ablation maintained it at 37 months. We have longer-term data now that we showed at this meeting. No patient who was treated ended up generating higher grade pathology, and in fact, there were delayed treatment responses in 4 patients who went on to achieve complete response long term. This is CHARM 2. And if you want to hear about the fun experiences of running a randomized multi-center clinical trial through the pandemic, talk to me afterwards. It's not fun. So running this, first thing, we lost some clinical coordinators at our other center. Then they took alcohol off the market for a while. And then the pandemic, it ended up being underpowered, unfortunately. But we did show that alcohol is not necessary again, and that adverse event rates fall again. Unfortunately, we didn't have the numbers to show that with statistical certainty. But it essentially replicated what we saw in CHARM 1, just not as vibrantly. There was one serious adverse event with grade 3 severity, meaning that it needed treatment, and that was in the alcohol arm. This is the overall prospective data that we're presenting at this DDW. This showed 151 cases we've done over an over 12-year experience. When we look at our prospective data with long-term follow-up, we see that we have about 2% rate of serious adverse events, which was just pancreatitis, more than 24 hours in the hospital. And our overall efficacy is 79% when you take complete and partial and put them together. Remember, 2% is essentially what you saw with EUS-FNA if you did confocal. I'm going to run a little tight on time, so I'm just going to show you how this works. Essentially, you take the fluid out. You want to try to measure that. Whatever you took out, you want to put back in with the chemotherapy. And then essentially, you'll make sure there's no leaks in the line. Take air out of the line because you don't want to inject air in there. And you just simply replace that tumor to its original size and dimension. This is what it looks like in real time. I'm going to take all the mucin out of this cyst. No alcohol is involved. We just replace it with the chemotherapy. In order to make it easy for you, I've designed it so that when you put the chemotherapy in, it gives this incredibly vibrant snow globe, so you know where it is and where you didn't. Of course, it had nothing to do with that. It just happened to work out that way, and it's beautiful. You can see exactly where the chemo is. Where it's not, it's still going to be anechoic, right? It's this mucinous fluid. So you know exactly what you treated and what you haven't. The more cells you have, the harder it is going to be to treat. This one, it has a complete ablation. Then you're just going to follow that on long term. Remember what I told you before? How do you measure efficacy? It's MRI, MRCP measured at 0, meaning pre-treatment, and 1 year. Here's complete ablation. Here's another example. One of my favorite patients, she had a large tumor, mass effect. Here you can see hers at 3 years. I challenge you to find that cyst. It's not there. That's complete ablation. But just because I don't want to be accused of conference bias, here's a partial response. This does happen, as you saw in our data. This is the MRI on the top, MRCP on the bottom. That's a partial response. It looks like somebody just took the same tumor and ran it through the dryer a couple of times. It's about 80% less. That'll be stable. We've shown that in our long-term data, but it hasn't disappeared. So who's right for ablation and who's not? Most cysts are small. They're low risk, best followed by surveillance. Cysts that have stigmata malignancy, that should be evaluated by a multidisciplinary committee and surgery considered if possible. But the cysts in the middle, that's who we're talking about, and appropriate for ablation, that's who we think this is a good option for. It's just like those of you who do EMR ESD, you got referred to a lesion, you look at it, you're there to do EMR, but it's got figures of malignancy on it. You got to think, hey, is this better for colorectal surgery? This is the same thing. So we consider this for only high-risk, high-volume centers, for a trained multidisciplinary group, an interventional endoscopist, and it really should be done by a dedicated team with quality assurance factors. These are the groups that we've trained that are doing it now or planning on doing it now and in the process of setting up a program. It's growing in rapid adoption very quickly. And with that, only 30 seconds, not that bad, right? Okay. Thank you. Appreciate it.
Thank you, Dr. Moyer. So we're going to talk about the next ablative modality, that EUS-guided RFA. So initially, when I made the deck, there were a lot of technical kind of expertise skills. Then I couldn't time it less than 10 minutes, so I had to delete it at the last moment. So I do want to show some results and still kind of stick with technique. So we conducted a single center prospective study evaluating EUS RFA for ablating branch duct IPMNs. This was recently published, and it represents the first 12 months of enrollment and up to 18 months of follow-up. So it's prelim data. And in this prospective study, we enroll patients with pre and post ablation. Endomicroscopy was pre-ablation, but NGS was pre and post ablation in those who had partial response. So also we used 3D volumetrics, computerized segmentation for measuring cyst volume pre and post for being very highly accurate in estimating post-ablation volumes. So these are the published results from our early experience with the ARRAYS study. So we observed more than 50% reduction in nearly 80% of subjects, while 40% had complete resolution. 88% of those with partial response had pre and post ablation NGS showing molecular clearance. Now, the mean size of cyst treated was higher than prior published studies. So the mean size of cyst was 4.6 centimeters, and the adverse event rate was 12%, mostly due to the thermal impact of RFA. Now, this is the extension of the same array study. This is the latest update. RFA was performed in 40 branch duct IPMNs in 35 patients involving 53 sessions. The mean lesion size was 4.4 centimeter. And in 35% of these, there were high-risk features, which were either by NGS or endomicroscopy showing high-grade dysplasia or Kyoto variables showing high-risk stigmata. A mean of 15 RFA applications were applied per cyst, and the total mean duration of RFA alone per case was 5 minutes. And the results are here. So in this update, 73% of the cases achieved greater than 50% volume reduction, and a complete response was observed in 44%. Overall, median volume reduction across all the cases was 83%. So when you compare the prior published to the current, what are the few changes? We have had a 40% increase in patient volume, and we have a longer duration of follow-up. The partial response is more than 50% response. It's more than 50% response is stable, around 75%. The complete response rate has improved to 44%. The adverse event rate stays stable. And for the first time, we had enough sample size to do a multivariable analysis to predict response. So in this multivariable analysis involving in identifying predictors of volume response, so 3 independent predictors reached statistical significance: smaller baseline cyst size, absence of associated pancreatic duct dilation, and a greater number of RFA applications per session. Interestingly, multiseptated cysts showed a trend towards better response, but did not reach statistical significance. An important key point is that from this, that comprehensive coverage is critical in branch duct IPMNs when we ablate. So these are the adverse events. It's a technology which we are still learning. So overall adverse event rate of 13%, and most of the adverse events are in the head and uncinate, and it's all due to the thermal impact due to the structures which are close by. Interestingly, most of these events occurred in 2023 and 2024, and we just had one episode, one adverse event in 2025, suggesting that there is a learning curve to this process. So one of the key issues why we do have adverse events with RFA is because of the limitation of EUS itself. EUS is 2-dimensional. A strong 3-dimensional understanding of the surrounding anatomy is therefore critical, particularly for kind of appreciating the radius of the thermal energy around the RFA probe within that tight aspirated cystic lesion. So there is a learning curve, and one gets, we do get better as we try to do more of these. I would say I was presenting this in a session yesterday, and Dr. Shami did point out probably better to try it in the body and tail first before you go to the head of the pancreas. So in terms of procedure technique, here is a list of all the items you're going to need. Patients do get prophylaxis with rectal indomethacin and ringer's lactate. And just going through this procedure, we will look at the video and just follow along. Here is a multiseptated cystic lesion in the body and branch duct IPMN prior diagnosed. We aspirate the cyst with a 22 or a 19 gauge based on the viscosity which you would have documented from a prior EUS. And once the cyst is, all the compartments are aspirated, you have to leave a small target because you have to take the needle out and then use the 19 gauge RFA needle to go into that target. So leave a small fluid pocket, and then you introduce the RFA needle. Then you start from distal to proximal, starting ablating at multiple points. And in the next slide, I'm going to tell you the technique to ablate as well. So when you ablate, you will see some white bubbles, which is the kind of the vaporization bubbles. That kind of doesn't mean anything. It's just that, it's the interaction of the probe with the tissue. And what the indicator is that if there's a spike in the impedance, then we stop or we let it go till 45 seconds. After ablation, it's important to examine by EUS and also the point where the needle went in with the scope. You can use the same linear scope to examine that mucosa over there. So the technique kind of works in two planes. The limitation being EUS is two-dimensional. First, the target the cyst. So you have one axis with the elevator or kind of forward and backward movement of the scope tip itself. And then you have another axis perpendicular. So when you start in a distal end of the lesion, when you ablate a point, turn your body to right or left, you will see the needle disappear. That's okay. But then you apply heat. Very safe to do it in the body, but in the head, you have to be careful about the bile duct and pancreatic duct, which are right around the lesion. Given the fact that you have aspirated the cyst, they're much nearer than when the cyst was full. So in this kind of a two different plane ablation, you want to cover as much area of the cyst as possible. Now, our experience is in these larger lesions, the mean size we have treated is 4.5 centimeters. And in smaller lesions, obviously, it's going to be much more challenging. So here are some responses. Here is a 3.5 centimeter multiseptated branch duct IPMN in the head of the pancreas with a complete response, which you can see on follow-up MRI at 2 years. The second lesion is a 4 centimeter IPMN in the head of the pancreas, again showing a complete durable response at 3 years. And this next is more of a partial response. It's a multiseptated lesion extending all the way head and to the genu, very challenging to ablate. It's about 4 centimeters in size. And, once we ablate, we get the smaller compartments. And the reason why we use 3D volumetrics is to individually measure each of those. So we get an accurate estimation of volume. So here is an 80% volume reduction in a three-dimensional volume calculation. But at this point, how much of that is viable versus not, that's another kind of, as far as biological response, it's an investigation which we still need to conduct. So here is another example. This patient will always be etched in my memory because she was declared as a non-transplant candidate with liver cirrhosis. And here is a body cyst, nearly 4 centimeter. And we ablated, and the patient went back to the transplant board and successfully got a liver transplant. And here is another interesting case where the first round of ablation in the head of the pancreas, about 3.5 centimeters, there was no response. And we still don't know why some don't respond at all sometimes. And then second round of ablation, the lesion was gone. And here is another kind of a partial response. The genu and the head, the lesions which go across genu and head tend to have little challenges. And in some of these, what we have really started is that when they have a partial response, we're trying to get them back and do Dr. Meyer's chemoablation protocol in these partial responders. So in conclusion, EUS RFA is feasible and reasonably safe in large branch duct IPMNs. A volumetric response is meaningful and sustained over time so far. Molecular response is encouraging, though long-term data are still needed, and we still don't know exactly what it means, whether it will be reemergence of the same markers or there'll be a new clone in that area. And finally, I think what we are at, you listen to both ablation talks, chemo and RFA, and different kind of cyst morphology. So I think at the end of the day, it has to be a cyst morphology-driven selection of ablation modality, depending on the center and the expertise of the advanced endoscopy at the center. Thank you.
Good morning, everyone. Since we are running on time, I'll try to finish this in next 5 minutes. So today I'm going to take you out of world of cyst and get you to the solid tumor, mainly pancreatic cancer. So we initially 10 years ago published our first trial. This was a prospective trial, 10-patient feasibility study, where we had unresectable and metastatic 10 patients where we did EUS RFA with chemotherapy. We showed a survival of about 19 months, which was higher than what you would expect. One of the patients in this trial had a 2 centimeter pancreatic mass as well as large mediastinal lymph node, had a progression of disease in FOLFIRINOX, treated with RFA of a primary site as well as the mediastinal lymph node. And to our surprise, he had a complete radiological response at 2 years. We ended up continuing chemotherapy for next 7 years. And then at that point, we offered him a Whipple surgery. And this patient is still alive. And some of these anecdotal cases gave us a lot of encouragement that there may be something in this technology. We subsequently have done a lot of mice experiment trying to figure it out, how RFA changes the tumor microenvironment, how we can leverage RFA-induced immunomodulation. And at that point, we started 2 clinical trials, what we call pan-cardinal trial. We have first trial focusing on resectable cancer, where we do RFA along with neoadjuvant chemotherapy in a very structured, standardized protocol. This is an NIH-funded study. And same time, we realized as this trial started, a lot of the patient came to us would not fit very strict criteria. So we actually started a prospective registry where patient who even did not meet the criteria, we did offer them EUS RFA. And in registry, we treated all patients. So to this date, we currently have 46 patients enrolled in a Pan-Cardinal 1 trial, about 100 patient enrollment completed in a prospective registry, combining both over 850 US RFA procedure. In a prospective trial, we currently do RFA 4 weeks apart after second, fourth, and 6 week cycle of chemotherapy. This is how the Pan-Cardinal trial protocol looks like, where you can see the weeks of chemotherapy, weeks where we do EUS RFA, where patient gets a CT scan, and where patient goes for surgery. So let's review some of the data from both trials. So when we look at a resectable pancreas cancer, what is current standard of care? If you look at all the published literature, very, very high quality studies, you look at it, resectable pancreas cancer, survival can range from 21 months to 54 months. Highest you are seeing is on a PRODIGE trial. This is an upfront surgery, whereas a highly select group of patients was offered upfront surgery followed by FOLFIRINOX. That's the highest survival you see. And what we are seeing in a prospective registry, we had 10 patients that were treated with a US RFA, and current median survival in that group we are tracking at 68 months. 12-month survival probability is about 80%. Same with Pan-Cardinal 1 trial. So first 10 patient I showed was prospective registry. They were still resectable, did not meet inclusion criteria because they came to us late, 3rd week or 4th week, so they already had chemotherapy, so I had to put them in prospective registry. Now in a Pan-Cardinal trial, these are the 42 patients, and again, survival currently tracking 54 months, 12-month survival probability about 80%. Now moving on to locally advanced cancer. Again, looking at current standard of care, you can see various degree of survival, about 13 to 19 months. And in our current data, locally advanced, we had about 24 patients, and we are tracking survival of 19%, 12-month survival probability 68%. Moving on to metastatic disease. Again, this is where survival starts to really dip, ranging from 6.7 to 11 months. And in our trial, 38 patients, current survival is about 17 months, 12 survival probability 71%. Now it starts to get really interesting that we decided that based on our mice experiment, we saw that there is a higher expression of PD-L1 post-ablation. We did mice experiment where we combine post-RFA immunotherapy, where we give PD-L1 checkpoint blockade, and we saw those mice actually had a better survival, better tumor response. So in this prospective registry, there were about 9 patients we were able to get compassionate use pembrolizumab, and we did RFA, so they got standard of care chemo. They got RFA, but we also added immunotherapy. Yeah, and in this patient, so if you look at first 32 patients, survival is 14 months. But the next group of patients where they got
also immunotherapy on top of that, that survival is increasing to 12 months. And this is in a prospective trial. We learn a lot of things. Initially, I just offered 2 or 3 ablation and we stopped it. But subsequently, as this trial is ongoing for last 2-3 years, and same time we are doing a lot of mice experiment, we learn that there is no reason to stop it. Repeated ablation leads to more sustained immune response. And in the later half of the trial, we've been offering ablation. So I do have metastatic patients who may have undergone 14 procedures, and their survival is currently 36 months. Most important thing is that during these trials, we saw significant improvement in patients' performance status. So their pain scores are better, they are eating better, their nutritional status is better. Majority of patients, you can get them down to equal 0 or 1. So overall, their quality of life is improving. I just want to recognize my team, but at the end of the day, this is still a single center, prospective, single arm trial. So we are getting ready to start a multi-center crossover trial in a metastatic disease where we will be offering them standard of care chemo versus EUS RFA. And if there is any progression, then patient can cross over to RFA arm to see that we can prove that this technology has a really role in a treatment of pancreas cancer. Thank you very much.
Good morning. I'm Fatih Howell. I'm one of the advanced endoscopists at Henry Ford Hospital in Detroit, Michigan. And I would like to thank Dr. Krishna for allowing me to participate in this wonderful consortium, and also thank you to the course directors for this wonderful morning. I also want to just acknowledge Dr. Angela Luthra, who we adopted the slides from the prior years. It helped a lot in forming this updated slide deck and put it on together. So now we will shift to the financial aspects of EUS NCLE and EUS RFA. Starting with Cellvizio for institutes who are interested in considering incorporating confocal endomicroscopy into their practice. This is an overview of the capital costs associated with it. The estimated cost, including the processor for Cellvizio, the installation, staff training, and support is in the ballpark of $200,000. The cost for the AQ Flex 19 probe, which is FYI, each probe is good for 10 uses. This is about $11,000. But it should be noted that the capital costs here are actually the investment commitment of your institute into this program, and they're not incorporated into patients' billing. That being said, if the institute is unable to fully purchase the equipment, then Mauna Kea do provide other alternative options, including a lease option, which is payment over time, and a pay-per-use option, where there's an initial upfront cost for the processor, the staff training, and the support, which is about $5,500, and the equipment will remain owned by Mauna Kea, and there is no minimum use requirement. For the radiofrequency ablation, the capital cost of the RFA generator is about $50,000, and the single-use RFA needle is about $3,000 per unit. Taimung here also offers lease and rent per day options. And from a cost-benefit standpoint, the generator can also be used for biliary RFA, in addition to RFA of both solid and cystic pancreatic lesions, better justifying the capital cost associated with the generator. And this is something we're doing at our institute as well. So the following few slides is where the money is, pun intended. I will be listing the currently available CPT codes for both NCLE and RFA. And the numbers listed are from CMS national averages, so they may vary based on the payer that you're dealing with. It is imperative to understand the coding for these procedures and to make sure that they're actually included in your billing system. Starting with Cellvizio, you basically have 2 CPT codes, which are in bold here. The first is 43238. And this captures the AUSFNA portion of your procedure. And then you have the 43252, which captures the confocal endomicroscopy portion. Interestingly, there's also a separate code, which is 88375, which is the NCLE interpretation performed by a different physician other than the performing endoscopist. I also included the last code here at the bottom, just for the purposes of this talk, which is 43242. And this is our most standard and most widely used code for EUSFNA. This code should not be used for Cellvizio, as I will explain at the next slide. The recommended code for Cellvizio procedure is combining the 43238 and the 43252. And this specific combination of coding is eligible for what we call complexity adjustment. And what that means is when that code is submitted, the CMS will take that code and then raise the claim to the next higher paying clinical ambulatory payment classification. And with that, this results in a facility reimbursement of just under $4,000. So you're technically getting reimbursed at 100% for both of these codes. We can also see that there is an additional RVU amount here, additive work RVU amount when compared to our standard EUS procedure, and this will usually serve towards your total RVU productivity. It is important to note that complexity adjustment does not apply when we combine the CPT code 43242, which is our standard EUS FNA code, with 43252. That's why we should not be using these two together. And in this situation, the MPPR, or the multiple procedure payment reduction rule, will apply, where your primary service gets reimbursed at 100%. The secondary service may undergo a percentage reduction based on the payer. This slide illustrates a simplified version of the break-even analysis for Cellvizio capital costs, taking into account the major expenses associated with Cellvizio. And I'm just going to guide you here through it. So if you take the AQ-Flix probe cost per case, which ends up being about $1,100, you subtract it from the total same-day facility revenue based on the complexity adjustment, you end up with a net facility revenue per NCLE case of about $2,839. And generally, if you take that number, the facility will need about 71 cases to break even on the $200,000 capital investment into the processor. And a moderate to high practice volume will take about 6 to 15 months roughly to reach that break even. From a RFA standpoint, the combination here is 43238, which captures the EUS portion again, and there's the 43270, which then captures the ablation component of the procedure. And you can also submit a 48999, which is an unlisted procedure of the pancreas, but with this code, you need to provide additional documentation about the specifics of your procedure. EUS RFA coding is typically subjected to the MPPR rule, and the work RVU also remains additive for your RVU productivity when compared to a standard EUS procedure. So far, based on what we have learned in this consortium, that the utilization of NCLE and RFA is not only clinically effective, but it can also be attractive from a financial and a business standpoint, which justify the investment commitment of your institution towards this program. Few other points that help strengthen your proposition to your administration is that there is a growing patient's desire for minimally invasive treatments for pancreatic cystic lesions and solid lesions. There are also cost savings from prevention of unwanted pancreatic resections. And these patients, not infrequently and actually frequently, may require more than one procedure, which is favorable to any institution. Adding to all that, expanding the indications of these technologies can also help offset the capital costs associated with them. NCLE, for example, is being increasingly used in guiding ablative therapies for Barrett's esophagus with dysplasia. It also has a role in gastric intestinal metaplasia, and more recently, it's being utilized for IBS food tolerance testing. So other areas to explore. In terms of RFA, this modality can be used, as we saw, for both solid and cystic pancreatic lesions, including PNET and PDAC. And we've also been using it for celiac plexus ablation for patients with malignant type pain. Lastly, I wanted to highlight the long-term return on investment and the downstream revenue that can be generated within the institution from these technologies. And I want to emphasize that patients with pancreatic cysts, pancreatic lesions do not only yield revenue for the GI department, but they can also contribute to multiple divisions and specialties within the same health system. Those patients will require, as we saw, ongoing surveillance with lab work and cross-sectional imaging. They may undergo genetic counseling and testing. They will be evaluated by our surgical oncology colleagues and may undergo surgical resection for the high-risk lesions. And most importantly, which is kind of dear to my heart, it also contribute to center development and establishing a pancreas program that can help and serve our communities. For example, at our center, we have already had a pancreas cyst clinic that is staffed by physician assistants and surgical oncologists. And they work very closely with us to trying to develop a multidisciplinary approach to how best to manage these patients. And when we started incorporating NCLE and RFA, this truly enriched our partnership with our surgical oncologist colleague. And now we are providing even better care for our patients and our community. I wanted to acknowledge our amazing team and leadership at Henry Ford Health and our colleagues from the Pancreatic Cyst Clinic, and thank you all for your time.